Well, thanks for coming tonight. I know there's a lot of, I know it's a real sacrifice for you to be here tonight with all the things that we can do in Springfield. So I really appreciate you being here. I'm an anesthesiologist, and I specialize in treating patients with different types of pain. And so tonight I'm going to talk about probably the thing that I see the most in my practice, which is different types of back pain and neck pain. And I'm going to talk about those topics using a few different types of case scenarios. So we can introduce causes for back pain, some of the treatment options, and then things that are useful skills for patients who have chronic pain to be able to learn. So let me read this slide. This is our first case study. JB is a 56-year-old man who reports low back pain at his annual physical. He's not seeking treatment for it. He states he doesn't have time to worry about it. With all the work involved in maintaining his farm, he feels that nothing can probably be done anyhow. So back pain is a pretty chronic problem. Let me give you some statistics. In a study done in the journal Spine in 2005, it reported that the annual incidence of back pain in all adults in the United States approached 19%. That's almost 1 in 5 adults in our country. And of those who develop back pain in any year, 40% of those patients will continue to have persistent symptoms. So back pain is a big problem, and there are a lot of healthcare costs associated with it. In 2011, the National Academies of Sciences Institute of Medicine issued this report on chronic pain conditions in the United States, of which back pain is a large one. They found that chronic pain conditions affect at least 116 million Americans. And the cost associated with that is staggering. As much as $635 billion in both direct medical treatment costs and the cost of lost productivity. And so it's important to be able to address back pain early on and prevent acute pain from becoming a more chronic, disabling condition. Let's look at our next case study. TR is a 67-year-old woman with arthritis and spinal stenosis who doesn't want to be a bother to her children. She tends to stay at home because standing and walking activities increase her pain. She's found that some types of pain medications decrease her pain level and allow her to be more active around the house and more social with her family, but she's worried about becoming addicted. I can tell you, I probably see somebody like this in my office almost every day. What this patient has is a couple of pretty common degenerative pain conditions that can lead to persistent back pain that can be quite disabling. Let me talk about some of the treatment options that can be offered. In going back to her, in her case, her doctor only gave her one line of treatment, which was pain medication. And she has some concerns associated with having to use pain medication long term. Well, as an anesthesiologist, our approach to pain is a little different. Let me first talk about some of the different conditions that can cause acute pain and lead to more chronic pain. The first 2 or 3 on this list here, degenerative disc disease, spinal stenosis, and spinal arthritis, these are all conditions that unfortunately will just develop gradually over time. They're degenerative changes, and in some patients they're not necessarily symptomatic, but in some patients they can suffer some sort of injury and turn one of these conditions into a problem that becomes painful. In degenerative disc disease, what happens is that the discs, these are these little cushions between the bones in your spine, gradually wear out over time. They lose water content and the disc starts to shrink down. Sometimes the stuff inside the disc can squish out, and that's called a disc herniation. In turn, as the discs degenerate, it can lead to a couple of these other conditions. Spinal stenosis refers to narrowing. So basically, as the disc wears down, the bones get closer together, and so that can result in basically squishing of the nerves in the spinal cord centrally, or as the nerves try to exit from the spinal cord. Additionally, as the discs degenerate, it creates pressure on the posterior elements of the spine, where the spinal joints are. And that increased load can lead to spinal arthritis. Sciatica describes a condition in which patients feel pain that starts in their back and then radiates down their leg. Frequently, the sciatic nerve isn't actually the culprit in this case, but usually there's a problem in the spine. With trauma, any of the first four things can become more symptomatic. And additionally, trauma can lead to spinal fractures, whiplash injuries in the neck, and really the most common thing that causes back pain is just different types of muscle injury. So in this case study, this patient was offered medication. And really, that's a pretty common scenario. You go see your doctor, and frequently, in the way medicine's practiced now, we're inclined to prescribe medication to take care of something. And I can tell you that in acute settings, that can be a useful thing. It has a role, but it's just one component of a complete pain treatment. Different medications that can be useful in treating acute pain, some drug classes would be things like the anti-inflammatory medicines. So things like ibuprofen or Aleve, some prescribed medications like Celebrex or meloxicam. Those are things that can be helpful short term. If the inflammation is severe, sometimes your doctor may prescribe steroids to use. Skeletal muscle relaxers can also be helpful if there's a significant spasming associated with their pain. For more chronic pain conditions, your doctor may prescribe medications like antidepressants or some of the anti-seizure medicines. These medicines have some unique properties in helping to reduce pain transmission, so that's why they're used. And then finally, probably the most commonly prescribed class of medications are the narcotic medications. And over the course of my career, I've started to see a shift in the role that narcotic medications should play in treating pain. Early on, the thought leaders in my specialty were strong advocates of prescribing pain medication and potent pain medication more frequently. They thought that patients were being undertreated and suffering unnecessarily. And so really starting in the early 90s through the 2000s, what we've seen is a gradual increase in the prescription of narcotic medications. But what we didn't anticipate seeing, though, was the corresponding increase in problems associated with narcotic pain medications. What we saw that paralleled the rise in prescribing pain medicines was increased problems with diversion, abuse, and really the most serious side effect of narcotics, which is overdose and death. And so a number of studies have looked at the efficacy of pain medication for treating chronic pain, and most of the studies find that it is useful, but only in the first maybe 3 or 4 months of a condition. There really aren't any studies that show that that it's superior past that time. Now, having said that, I think that there is a role in using medications on a more long-term basis. Certainly for conditions like cancer treatment, there shouldn't be any restrictions with prescribing medication to treat people at the end of life. However, it probably is only a small percentage of patients that can see any significant benefit from long-term use of pain medication. And so what we're seeing in my practice and amongst other pain providers is that the criteria for wanting to put somebody on medication and large doses of medication have to be pretty stringent. And so a lot more judgment needs to be used and a lot more monitoring needs to be used to safely prescribe those medications. Like I said, I'm an anesthesiologist, and so with my training, what we do is take an interventional approach to treating different types of pain. And so our interventions can involve different types of spinal injections and nerve blocks. And in these procedures, what we're doing is directing specific medications, things like local anesthetics, steroids, sometimes opioid medications, to spinal nerves and spinal joints. The idea is to try to provide relief of pain while the body is healing the underlying cause. Another treatment that we offer in our clinic is this, radiofrequency rhizotomy. And this refers to a specialized pain treatment in which we actually destroy spinal sensory nerves for conditions such as spinal arthritis. What we do is, it's a non-surgical procedure. We place specialized needles adjacent to these sensory nerves along these spinal joints. And then we're able to direct a type of electrical energy, radiofrequency energy, to the tips of the needles, and that actually creates very precise lesioning of just the sensory nerve. It takes the body anywhere from 6 to 18 months for those nerves to regenerate. And so patients with certain types of spine arthritis that are a candidate for this procedure can get pretty prolonged relief from that. Spinal cord stimulation and the next device I'll talk about, spinal pumps, are both more invasive treatments for chronic pain, and we would consider them last-line interventions. In spinal cord stimulation, what we're doing is placing these specialized electrodes along the spine here. And when those electrodes are activated by these generators, it causes the patient to feel a tingling sensation that overlaps where they feel their pain. And so the tingling is a pleasant sensation. And what patients find is that they experience this tingling in place of their pain. Patients undergo a trial first to see if it'll help. They need to see significant relief of pain during this trial, in which we place a temporary catheter. And they get to use it at home for several days, and at the conclusion of the trial, they come back and they tell us to what extent it helped their pain. If it's significant, then they could have the device permanently implanted. Spinal pumps are another way of addressing severe intractable pain in patients. This device can deliver potent pain medications, narcotics, local anesthetics, some novel proteins directly to the spine. And those medications help to block or reduce pain in patients who aren't able to tolerate oral medication, or they're not candidates for surgery, or really they've failed all other treatments. The downside with this treatment, though, is that it really only helps patients with pain from about their waist down. Patients who have problems with headache or chronic neck pain or upper body pain, the medication isn't able to migrate up high enough to help without causing other side effects. So these are all the different interventions that we're able to offer as part of a comprehensive pain treatment program. Let's look at another case study. ML is a 48-year-old man who reports experiencing low back pain for 6 weeks. Since he began experiencing low back pain, he has tried to reduce his physical activity as much as possible because he's concerned that physical activity will make the pain worse. He lives alone, doesn't have many friends, and that pain has caused him to miss work and stay at home more because he has been feeling down and just doesn't want to go out. There are a lot of different factors that can predict whether or not somebody's going to develop persistent disabling pain, and they're not all medical. In this particular case, this patient actually has a couple of what we would call yellow flags that would make us concerned that he may develop a long-standing pain problem. The first idea is that his belief that pain and activity are harmful. And while it's true that after an acute injury, it's reasonable to maybe rest for a day or so, depending on the nature of the injury, it's really important for patients to start moving again, to start becoming more active, returning to more normal activities. The problem with prolonged rest and being inactive is that it can lead to developing stiffness, muscle spasming, loss of range of motion, loss of strength, and all of those can delay healing and prolong pain. Another yellow flag in somebody like him is somebody who's predisposed to low or negative moods or withdrawn socially. People who have problems with claims and compensation at work, problems at work, poor job satisfaction, they have heavy workloads or unsociable hours. These are all non-medical factors that influence how somebody perceives their pain and deals with their pain, and can lead to more long-lasting pain complaints. So what can be done for somebody like this? Anybody with a musculoskeletal injury is going to benefit from early referral to physical therapy. Physical therapy involves active and passive treatments that can help strengthen muscles in the neck and back, improve range of motion, reduce spasms, and they can teach patients how to reduce their pain. Some of these treatments can include stretching, spine stabilization exercises, hydrotherapy. There can have modalities such as electrical stim or ultrasound or TENS that can help relieve muscle spasm and also reduce pain. So early referral to physical therapy can be a huge help for patients, get patients back to normal activities. Behavioral and cognitive therapies also can have a role in treating pain. Pain often produces psychological and cognitive effects that can include depression, anxiety, fear, anger, and so some of these approaches can be really helpful in helping to address that. But the treatment programs can include education, relaxation and calming techniques, modifying thoughts and feelings, even simple things like scheduling pleasant activities can help. The goal of these interventions is to try to help reduce pain intensity, pain interference, some of these weird fear avoidance beliefs, work-related disability, time for sick leave, and depression. So counseling can have a big influence, especially in the patient used in this case scenario. The complementary and alternative medicine treatments can include things like acupuncture, chiropractic care, biofeedback, some nutritional therapies, and really there are many people who have a distrust of Western medicine, including my in-laws. They would prefer not to see their regular family doctor, but but use an alternative or complementary health provider. And honestly, I'm not offended by that. It doesn't bother me. As a physician, I just want to see you get better. And so if you can see your chiropractor and they're able to help you address an acute flare-up of pain and they've helped you before, that's great. I don't have any beef with them. They can help certain conditions. Now, if it gives me pause if they say, well, I can also take care of your diabetes or cancer. I don't know if that's a reasonable expectation. But for addressing musculoskeletal pain and disorders, that's fine. And so I would not discourage you from doing that. Now, if you have to keep going and going and going, then and they're not able to address your problem, in a week or so, or 2 or 3 weeks, then you might want to consider, seeing your doctor and then seeing what other options you might have. Okay, let's go on to our last case study here. NL is an active 38-year-old carpenter who has back pain from a recent injury which is interfering with his work. He was seen by his workers' compensation doctor associated with his workplace, but he lost his job. Was told the back pain was a pre-existing condition and was denied for his workers' compensation claim. In somebody like this, interdisciplinary treatment involving all of the different things we've talked about can really help prevent development of persistent, chronic, disabling pain. Somebody like this could get referred to physical therapy early, treatments including work hardening, some of the interventional therapies that we do in our clinic. Pain medication on a short-term basis can be really helpful, and something like this, counseling also can help. Unfortunately, there's a high cost associated with that, and if insurance is limited, this type of treatment approach may not be practical or possible. So what if you already have chronic pain? What can you do? Well, there's some skills that patients can learn that really are, I would consider essential in learning how to manage, not get rid of, but manage your pain. First is understanding. It's important for patients to really have a good understanding of what their diagnosis is. And many times when they go to the doctor, they're not able to get all their questions answered about what they have. And probably a lot of it is the physician's fault, our fault in maybe using terminology that is unfamiliar, and patients may be embarrassed to ask, and so you have to remember, you're the customer, you're the person that's being served by the physician, and you need to be satisfied that they've been able to answer your questions. With the internet today, a lot of times people will go online and do research, and believe it or not, you can't believe everything you read on the internet. Besides the internet, you may have well-meaning friends and family that they may give you some false information and lead you to having false beliefs about what you have. And so education is very important to really understand what you have. The other thing that's important in understanding, too, is that hurt doesn't necessarily mean harm. If you have a chronic pain condition and you still have pain, that pain, one way to think of it is that pain represents your body's memory of the original injury. So it's not you're not doing ongoing damage by feeling pain. And so even though you have pain, we would encourage you to continue to try to be as active as possible and and knowing that you're not hurting yourself more, pushing yourself past that to continue to do activities of daily life and things that you enjoy. Movement is really important, and so it shouldn't be avoided. Okay, accepting. This is a really important skill, to be able to, for a patient to accept his or her situation and try to decrease the emotional struggle associated with it. It's just not helpful for patients to just give up and not do things to try to make their lives better. Really, a simple approach to this would be just changing your line of questioning from, why me, woe is me, to what now? What should I do now? What can I do now? And what are the things I can still do? It's important for you to try to work with your doctor to develop appropriate and realistic expectations about your activity. Calming is important. Chronic pain patients can cause you to be, or chronic pain can cause patients to be in this constant state of fight or flight and stress. And so it's essential for patients to be able to learn how to calm their bodies down. There are a wide array of different relaxation techniques. And there are even techniques that can help you trigger the body's own calming response and release natural endorphins. When I talk about balancing, really it refers to balancing in all areas of your life. It has to do with activity pacing. So when you have a project you want to get done, some people tend to just keep working on it until it's completed. They can't stand leaving something undone. And so even though they're having terrible pain, or they know they're going to have terrible pain afterwards, they push through it. And really, it's not helpful because then you may be laid up for 2 or 3 days. I have patients that come in and tell me that all the time. They come in, well, I helped, put in a brick patio. And so, I was laid up for several days, and their pain's still flared up, and they need to see me. And so, I tell them, understand what your reasonable limits are, and regardless of the activity, take time to stop, stretch, rest, take a break, and just understand that your pace may need to be slower. You need to be able to manage your time a little differently in balancing. Another part of this is good sleep hygiene. And frequently, patients with chronic pain may have difficulty with sleeping at night, and because of the pain, they end up having naps during the day, and really that really messes up your sleep cycle. And so getting a good night's sleep is really important, and so that's another part of this. The other thing patients need to realize too that have chronic pain is that they know how much good time that they have over the course of the day. And you should be able to set aside part of that good time to spend on things that you really like doing. Spending time with the people you want to be with, doing the activities you want to do. Know how much good time you have, and then take that into account. Okay, and finally, coping. So these are tips, techniques, and plans you need to have in place to use when the pain becomes more severe. It may include, resting. It may include using ice to an area or heat, massage, some analgesic creams, using a TENS machine. Those are options. Another important one is distraction. Engage in some activity that occupies your mind during these flare-ups. So if you like to do puzzles or play games or talk on the phone, engage in those things to keep your mind distracted. It's amazing how much you forget about the pain when you're busy doing something else. So back and neck pain, there can be a lot of different things that cause it. Most of the time, these conditions can be short-lived and treated easily with a lot of the options that we talked about earlier. But seeing your doctor early, getting the right diagnosis, getting involved in therapy early to restore more normal movement and range of motion activity, those are all critical in preventing an acute injury from becoming more common, more chronic. All right. Well, I'll be happy to answer questions after, including why I like the Cubs. And I actually put that slide up to help you understand that I really do understand pain and suffering. All right. So I will. Yes. So I'm going to yield to my colleague Madhvi now.
Thank you, Dr. Salvacion. That was a nice summary of what's available. We're going to look at pain a little bit differently from a physical therapy point of view. Obviously, I'm a physical therapist, so not here. Sorry about that. Okay, I lost my train of thought now. Just a little distraction, right? I'm Madhvi Kulkarni. I'm a physical therapist. So when we look at pain, Dr. Salvacion gave us a nice summary of the treatment options available right now. We're going to look at it a little bit differently from a physical therapy point of view, from activities, what you cannot do, what options do you have, what you need to look for. So to start with, what exactly is pain? It sucks. It's just unpleasant feeling. Nobody likes it. But sometimes you have to think about it as, your body is trying to tell you something. It's trying to tell you, okay, you're doing something different. You're doing something wrong. Something is causing pressure, tension at something. You better remove that trigger. So from physical therapy, I tend to look at pain as it's a protective response. It's a warning sign from your body. Let's get that trigger out. Most pain, once the painful stimulus is removed, usually goes away. Sometimes, as Dr. Salvacion just mentioned, it's the pain memory, then it becomes chronic. It just does not go away. No matter what you do, it just doesn't go away. And when it stays after that acute flare-up is resolved, it becomes a chronic pain. It is the most common condition, common reason patients seek medical care for. Obviously, it is pretty expensive. When we look at pain, when the patient comes in, just say, for example, you have back pain that's going down to your buttock, going down to your leg. You're choosing to come to physical therapy. I'm a physical therapist. Obviously, I'm going to say you made a smart decision. But we are going to look at, I'm sure most of you have had some physical therapy experience in your life. The therapist is going to look at certain things. The evaluation is going to consist of checking your range of motion, checking your strength. And the important questions that I like to ask the patients is, how does the pain behave? And what I say when pain behaves is, you're doing different activities, and you'll notice, especially the pain that comes from musculoskeletal problems, it changes. When you stand, it hurts at a different spot. When you sit, it hurts differently. When you're lying down, sometimes it goes away, sometimes it doesn't go away. It's just asking yourself, how is that pain changing? How is that pain behaving when you do different activities? If you're able to recognize those things, it will be a huge help to the therapist to figure out what kind of exercise program is best for this kind of condition or pain. as a therapist, I look at another concept called centralization of pain. I cannot go any further without mentioning Robin Mckenzie, who I followed closely, his theory, his books. He has spent countless hours observing and documenting all the facts about pain, especially coming from your spine, how the pain radiates, how the pain travels down your leg, where does it start, when it starts getting better, what happens to the pain. The concept he came up with has been researched well and shown that when you see centralization, you see a huge improvement at the end. Obviously, when you don't see centralization, the prognosis is not limited. So as a therapist, I'm going to ask those questions, how your pain is behaving. What is centralization? Centralization is simple. Say you have pain again in your back, going down to your buttock, going to your thigh, and you do something. You do whatever activity you do, walking, lying down, moving certain way, twisting certain way, and the pain moves from your thigh to your buttock and ultimately ends up in your back. That's centralization. Provided it stays there. Initially, you're going to find it doesn't stay there very long. It comes and goes. It's in the back, it's back to your thigh. It goes to your back, it goes to your thigh again. But ultimately, if you really be consistent with those activities that keep that pain in back, to take the pressure off the surrounding structures, you can maintain and manage that pain. The therapist is going to give you a lot of posture tips, do's and don'ts, and it sometimes just becomes overwhelming. What am I supposed to do? What am I supposed to not do? How do I know my posture is okay? How do I sit? Over 80% of patients report that when you bend forward or sit long, the pain gets worse. The simple thing to use is, again, that concept of centralization. If you sit a certain way and the pain starts going down your thigh, you know there's something wrong with it. You better change that position. You better change your sitting posture. Sit differently, move. Don't sit that long at one place. I'm sure you've seen this posture. I have a teenager, well, not teenager anymore, but we have had discussions about these postures all the time. Don't sit like that. You know you can sit a little bit better. I actually was watching one of the presentation at TED.com by Pat Matthews, and I liked his concept. He says, pain is the new smoking. It affects your lifestyle, it affects quality of life, it even affects longevity. So he has done an interesting study, and he has found that if you can sit on the floor, an amount of help, assist you need to get off the floor affects the quality of life. We know that. He's just proven it black and white. You probably will be surprised to know we bend forward about 3,000 to 5,000 times every single day. If you think about it, how much time do we spend sitting? How much time we spend bending forward? There's a nice video clip I found, and I hope you can hear it, but I will play it.
How much time do you spend sitting each day? If
Can you hear
work
it?
in an office, then the facts may surprise you. The Chiropractors Association of Australia recently looked into this very issue. It turns out that the average Australian office worker, after sleeping for 429 minutes, will rise and then sit to commute for 81 minutes in total. At work, they will sit working without a computer for 97 minutes. But for the majority of their office time, they will sit at a computer for 337 minutes, over 5.5 hours. At home, they will continue to sit at a computer for work for another 71 minutes, and then sit at their home computer for personal use for 115 minutes. They will sit for other leisure activities for 102 minutes, And finally, they will sit watching television for 132 minutes, or nearly 2¼ hours. So what about the other things they do during the day? What about things like standing, walking, running, going out for lunch, cooking, watering the garden, washing up, grabbing a few groceries from the shops? How much time is left for that? Just over 73 minutes. That's right. On an average working day, there's only 1 hour and 13 minutes left to stand, walk, and exercise. Just 1 hour and 13 minutes. It's a fact worth making a stand about. For more information, visit sitright.com.au.
Isn't that interesting? I was kind of surprised about 132 minutes of television watching, which I don't think average American has that much time to watch television to over 2 hours a day, but we do spend a lot of time sitting. So it's important to know what is a good posture. Typically, what's described as simple thing to do is sit extremely straight, like a really military straight posture. And if you let go about 10 or 15%, 20%, so just relax a little bit, that's a good posture you should be sitting in. That should give you a good support to your spine to manage the pain. Just simple tips I would like to, again, this is another video clip, and that shouldn't have any audio, so it should be okay. Just simple tips to maintain good posture. Just watch it sitting, bend forward, the laptop in the lap. Obviously, the neck is going to be strained. If you change that, you just raise the laptop, put something underneath so you don't have to bend forward to look at the laptop. Same thing, not only the back, but the way his arms are resting. That needs to be changed too. Really bad posture. Not only neck, but even the back. Just a little support to help you sit up straight. Again, sitting closer to what you're working on. Make sure when you sit too long, you know you're going to be sitting too long. Just take breaks. If you're traveling somewhere, if you're sitting, watching television, move something, move your joint, move your arms. Just get up and walk sometimes. It will definitely help. It does not have to be a big, elaborate walk of walking 2 miles. You can just take a break and walk inside your house. So the challenge I'm going to leave you with, first, be very mindful of your sitting posture, how you sit, what happens when you sit, where your symptoms are, where the pain is. Is it in your back? Is it in your leg? Simply avoid long-term sitting. As I said, break up the sitting posture, stay active. As I was talking to you about the TED presentation, staying active is going to keep the muscles flexible and strong. So getting up and off the floor or off the chair is not going to be as big of a deal and maintaining sitting posture is going to be easier if you stay active and keep those muscles going. Monitor your range of motion. A lot of times the muscle stiffness, as Dr. Salvacion was talking about, the stretching exercises, just simply doing some exercises to maintain that range of motion is very helpful. Listen to your body. If your body is telling you that it hurts, you better change that activity. You sit differently or you do something different to change that activity. Our goal is to relieve the pain. I thank you very much for being patient and listening.